Hi, my name is O.P. Hamanvik. I'm an endocrinologist at Brigham and Women's Hospital, where I help run our transgender program, and I'm very glad to speak to you today about care of the transgender patient. I have no disclosures, but I will say that all medications that I mentioned today are off-label. There are no FDA-approved medications for this indication. So today I'm going to give a broad overview of some of the principles of trans-affirming treatments. I will not go into a lot of details about doses and so on, but those you can find in the guidelines that I reference at the end. I will also talk about some topics related to regular health maintenance for gender diverse and transgender patients, and that will take us through today. I will also not spend any time on terminology. Hopefully, most of the words that I use will be familiar to you. And a very important topic that I just won't have time to talk about today is how to make your office a welcoming environment, and that is a topic for another day. So let's talk about our sort of current paradigm of how we might think about medical interventions for transgender and gender diverse individuals. So I'm going to talk about one of my patients. This is based on a real patient who was 52 years of age when I met him. And he was assigned male at birth and was still using his male name and male pronouns when I met him. So I will use that also at this point. And he reported that he had had gender dysphoria ever since he was in his early teens, but had actually tried some estrogen that he had gotten sort of on the street when he was in his 20s, and had some initial breast growth, and I think realized that life was going to be rather difficult, and just decided that he was not ready, that he was not going to pursue his sort of gender transition. So he ended up marrying a woman, and they have a 12-year-old daughter. And it ended up coming to me after there had been a lot of focus in the media on transgender individuals. He said that I don't want to be in my 60s like Caitlyn Jenner when I transition. And so he comes and is requesting estrogen treatment. He has not talked to anyone about this before, including not his family, no other medical providers, and the only support he has had has been through online communities. So this would qualify as a situation where the patient is transgender, and there certainly has been a lot more attention paid to transgender health and transgender topics in the media and so on. And it's actually not that surprising, because when survey studies have been done, as much as 0.6% of the population would identify as transgender or gender diverse. And that's a similar percentage to rheumatoid arthritis, just to give people a sense of how frequent that gender identity situation is. And these are sort of the typical steps of the medical interventions that we can offer for transgender individuals. The first step is to confirm that, in fact, the gender identity is different from the sex recorded at birth. And there's also an assessment for psychiatric comorbidities. Most patients will choose to proceed with transgender hormone therapy, and some patients might also want to have transgender surgery. So we'll talk about each of these in some detail in the next few minutes. But before we do, there are other parts also of caring for a transgender patient. The first part may not be so much provided by us as medical providers, but the patient might get a lot of support from peers. Especially transgender women might need voice therapy to help feminize the voice. Prostheses are useful, so breast prosthesis or penile prosthesis. And finally, there are many legal steps that are involved. Things like getting the gender marker changed on your driver's license, your passport, your birth certificate, and so on. And of course, any human needs primary care and routine health maintenance, and that is also true for transgender people. So that is also part of the medical care that we provide to a trans patient, which is not trans-specific. So let's start with the first step. So confirming the gender identity and assessing for psychiatric comorbidities. The first part of that, confirming the gender identity. So That's basically making a diagnosis, because that's sort of how our medical system works, that we need to make a diagnosis. And the diagnosis is gender dysphoria, which is the distress experienced by patients in whom the gender identity does not match the sex recorded at birth. And actually, sort of diagnosing transgender or gender dysphoria is pretty easy. If a patient comes to your office and they say that they are transgender, there really isn't a lot on the differential diagnosis there. But one can certainly go through the actual criteria and make sure that the patient qualifies. But the assessment for psychiatric comorbidities is important. The rates of psychiatric comorbidities have been reported to be as high as 70% in transgender people. Most commonly, things like depression and anxiety and PTSD. And certainly ensuring that those are being addressed is important. This first step used to be, in the guidelines, there was a requirement that these were addressed by a mental health provider. That's no longer the case. Any provider that feels comfortable addressing, sort of making the diagnosis and addressing the psychiatric comorbidities can do so by current guidelines for adult patients. In pediatrics, a mental health provider is still required. And part of that is just trying to make it easier for patients to get access to the care that they need. Similarly, there used to be a requirement for patients to have a so-called real-life experience where they had to live in society with a gender expression that matched their gender identity. And that has also been sort of gone by the wayside. It is actually quite difficult to pass in the gender of your gender identity before you've had any medical interventions. So I will say, while having a mental health provider on board is not a requirement anymore, I do find it very helpful, and especially in navigating some of the things that I do not have the skills. And so in the case of Mark, for example, I did suggest that a mental health provider could be helpful to help him with telling his family about his gender identity. And it turns out that they were also very helpful with how he would come out of work. And they helped address some of the distress and depression that he was experiencing also. So the next step typically is transgender hormone therapy. And this is it's very common that patients want to proceed with transgender hormone therapy. And the goal there really is for the hormones to promote a physical appearance that is more in line with their gender identity. And in doing so, you're alleviating some of the gender dysphoria that the patient is experiencing. In the case of Mark, who was a trans feminine individual or a trans woman, the treatment, of course, is to provide estrogen, and we typically use estradiol as the estrogen of choice. We can give estrogen in many different forms. We can give it as a tablet, we can give it as a patch, we can give it as an injection. And the pros and cons of each are similar to the considerations that we might have in a cisgender woman. But it turns out that the hypothalamic pituitary testicular axis is pretty difficult to suppress. So even with estrogen levels that are in the physiologic range, there typically is still testosterone being produced by the testes. So you need to do something else on top of the estrogen to block the testosterone, and that is most commonly spironolactone, which you will know as a blood pressure medication, as a mineralocorticoid receptor antagonist, and you will know that the side effect is gynecomastia, and that is because it also blocks the androgen receptor. So we tend to go for higher doses than what we typically use in patients who are taking spironolactone for other indications, and that will help block the effects of any residual testosterone. An alternative that is much more expensive but much more effective is to give leuprolide, which is a long-acting GnRH analog that we use, for example, in the treatment of prostate cancer, because it really does block the hypothalamic pituitary testicular axis completely, so that you end up with very low levels of testosterone. In the case of Mark, we went ahead and started him on hormones, and I'll show you some of the results of his hormone labs in a minute. But he is asking, and this is a very common question, what should I expect regarding breast development? So here's a question for you to think about. Which of these statements is true regarding breast development in trans women after 1 year of estrogen therapy? Option A is that most women will have a B cup or larger breast size. Option B is that having a normal BMI before starting treatment is associated with better breast development. Option C is that higher achieved estradiol levels is associated with more breast development. Option D is that adding progesterone will lead to larger breast size. And option E is that surgical breast augmentation is usually needed to achieve the desired breast size. So the correct answer here is E. Unfortunately, the effects of hormones on breast development is not what as good as one might hope. This is a study from Europe that looked at the difference between the circumference around the chest, where the dotted line is here, which was the fullest part of the breast, versus the second line here, which is the inframammary fold. And they looked at the difference in centimeters and assigned sort of a cup size to each of those. And as you can see, after about 1 year, about 50% of the patients had a difference of less than 8 centimeters or a cup size less than a AAA. So actually, as a B cup or larger is actually very rare. And there were no predictors. They looked at a lot of different predictors. They looked at age, smoking, change in weight, transdermal versus oral, the BMI, and serum estradiol levels, and none of them predicted the achieved breast size. So basically, there's no clinical or laboratory parameters that can predict the magnitude of the breast development, and most patients end up having inadequate breast development and choose to proceed with breast augmentation. So in the case of Mark, I did get some labs before he started on hormones, and the estradiol level was actually on the lower side, but the testosterone level was normal. And in this case, I started him on leuprolide, and with that, the testosterone levels dropped very, very low, as expected. And I also started an estradiol patch. And as is often the case, the patch has some difficulty with increasing the levels of estradiol. And I went up on the dose and still did not see much of a change in the estradiol levels. In hindsight, when I've used patches since then, I've had to use much higher doses of 100 to 200 micrograms patches. But in the end, in Mark's case, we switched to an oral estradiol formulation, and he was taking 2 milligrams twice a day, and finally we started to see the estradiol levels move. And I actually went a little bit up on the dose to achieve the target estradiol level, which is between 100 and 200 picogram per ml. The target testosterone level is testosterone levels below about 60 or so. And similarly in transgender men, you try to achieve testosterone and estradiol levels that are in the normal male reference range. During this time, I should also mention that Mark also started to use a female name and female pronouns, and she had help from her mental health provider that allowed her to come out to her family. Unfortunately, they did divorce, but the patient still has a pretty good relationship certainly with her daughter and also with her ex-wife. So just a word on hormone treatment in transgender men or transmasculine people. It's a lot easier. A whiff of testosterone will disrupt the hypothalamic pituitary ovarian axis very readily. As clinicians, you will know this from polycystic ovarian syndrome, for example, where testosterone levels are slightly elevated and the patient gets oligomenorrhea as one of the primary manifestations. Well, here I'm bringing the testosterone levels up to the normal male reference range. So complete amenorrhea is the rule. That's usually what happens. You don't need to add a second medication to block the axis. There are certain exceptions to that, but in general, you can get away with testosterone alone, and that can be given just like in a cisgender man, that can be given transdermally or by injection typically. Those will be the two most common routes of giving it. The side effects of hormones are going to be very similar in transgender and cisgender individuals. So there are no specific considerations in most cases. The one exception is that a transgender man can get pregnant, and testosterone is teratogenic, and therefore you need to be very aware of the patient's potential for getting pregnant. And if there is any potential that pregnancy could happen, then contraception is needed. An important part of hormone therapy in transgender people is to monitor the patients both for the desired physical changes as well as any adverse effects. And so I typically see patients back every 3 months for the first year or two, and then I space out the visits after that. And what I'm looking at is on the physical exam, whether they are seeing some of the desired physical changes. And also I look at blood pressure, which sometimes can increase, and weight, which often does increase. And so I try to ensure that the weight gain is not excessive. We measure testosterone and estradiol levels. And as I mentioned, we try to get those into the reference range for the sex that matches their gender identity. And finally, I look for side effects. And of course, some of that you can get from talking to the patients, but some of those are also lab tests. So I get electrolytes in patients who are taking spironolactone. Interestingly, in a recent study, there were no cases in a large academic medical center of hyperkalemia, even with high doses of spironolactone. And probably the reason for that is that the patients were otherwise pretty healthy, and so compensatory mechanisms were able to deal with the sort of trend towards hyperkalemia that would occur in someone taking spironolactone. In transmasculine people, I monitor their hematocrit to ensure that erythrocytosis does not develop. And then finally, as we're going to be talking about in a minute, I do keep a close eye on cardiovascular risk factors, and that includes a lipid panel and a hemoglobin A1C. There may not be dramatic changes in the lipid panel with hormone therapy, but there are certainly typically an increase in triglycerides, and there may be other changes also, although the studies are somewhat there's some discrepant or some varying results in the studies. As an endocrinologist, I also, of course, will keep an eye on the blood sugar. So the hemoglobin A1C is part of, maybe not every 3 months, but certainly once a year. The final test that I did not mention is prolactin. So prolactin has been noted to increase in trans feminine people receiving estrogen, and there have been reports of prolactinomas that likely started growing in the setting of increasing estrogen levels. So the current recommendation is to monitor prolactin levels, even though the actual incidence of prolactinomas in this setting is actually vanishingly low. And then finally, just a comment on transgender surgeries. There are many types of transgender surgeries. There are facial surgeries that are often sought by transgender women to try to help feminize the facial appearance, because the bone structure will not change with hormone therapy. There are what we call top surgery, so that would be breast surgery, either breast augmentation or mastectomy. And then finally, there's the bottom surgeries or genital reconstruction surgeries, where the genitalia are created that are matching the gender identity. Those surgeries in general are not actually performed by, or most patients choose not to have transgender surgeries, and part of that is access to care, both from a being insured standpoint, as well as actually finding providers who are able to do the interventions. So, most patients, but many patients also have no particular desire or need to undergo surgeries, and therefore they may choose not to proceed for that reason. But those that do proceed, the regret rate is very low, in the order of about 1%. And so typically it's a very reasonable thing to proceed with if the patient is interested. So we're now going to sort of shift gears, and we're going to talk a little bit about the bottom arrow here, the sort of primary care and routine health maintenance. And most of primary care is going to be similar to what the primary care that you provide to your cisgender patients. I will talk about a couple of topics where there might be some special considerations. But the important part here is that if a transgender patient comes in with a sore throat, the considerations are the same. In addition to what I will be talking about, I will add that that there are high rates of HIV infection, and so I do talk more about sexual health in my trans patients than I might do in a routine appointment with a cisgender individual. And there are also higher rates of intimate partner violence and hate crimes. So I also do talk more about safety, perhaps, than I might do in an appointment with a cisgender person. But for this, we're going to follow a different patient. This is Bunsri, who is a 47-year-old trans woman. She has had gender-affirming top and bottom surgery when she was 20 years old, so that would be 27 years ago, and was on estradiol for a few years around the time of her surgery. And in the setting of moving, she basically lost access to healthcare. And for about 11 years, she was off treatment, but has been back on estradiol for the past about 14 years or so. And she's actually feeling well. She's just coming for a routine PCP follow-up. On exam, her blood pressure, as you can see there, is 147/83. And she has the lipid panel listed here. So the first question is, she's taking estradiol. What is the effect of estradiol on her risk of atherosclerotic cardiovascular disease? Well, I wish I had a simple answer for you, but unfortunately, the data is not quite conclusive. The data from cisgender women may not fully apply to trans women, but the data that we have in trans women does show an increased risk of venous thromboembolism, so DVTs and pulmonary embolism, which is to be expected. But the risk on myocardial infarction and stroke is somewhat different from one study to another. It seems sort of overall, my read of the literature is that the risk of myocardial infarction is similar or perhaps only a slight bit increased than the risk in cis women, and probably similar to the risk in cis men. But the risk of stroke does seem to be higher in trans women, regardless of which population you compare them to, whether you compare it to cis women or cis men. On the other hand, in trans men, there's actually less data, but it does appear that testosterone does not increase the risk of atherosclerotic cardiovascular disease. Unfortunately, as is the case in a lot of trans healthcare, we do have a dearth of data, and so that makes making firm conclusions somewhat difficult. Well, one of the difficulties, though, is that in this patient, we might be interested in actually calculating what her ASCVD risk is using a risk prediction calculator, something like the pooled cohort equation or something like that. The problem is that there is no calculator that is using a transgender reference population to give you the risk of ASCVD. And therefore, you're not going to get accurate numbers from these calculators. So, even if you use them, do you put in male, do you put in female, what do you do? And I'll tell you sort of my approach, which is that I calculate the risk using both male and female gender. And then I take into account how long has the patient been seeing a male hormonal milieu and how long have they been seeing a female hormonal milieu. And so that helps me decide whether I'm going to trust more the numbers using female or the numbers using male as the sex marker. And then finally, for the ASCVD risk, based on the data that I alluded to in the last slide, I might increase the risk a little bit. And I'll give you an example for Bunsri. So in the case of Bunsri, when I used male gender, her ASCVD risk was 7.1%. When I did female gender, it was 3.5%. Now, she has not had a male hormonal milieu for very long, only from sort of puberty until age 18. And so most of her life has been a female hormonal milieu, although she did have some years with no testosterone and no estrogen. So I might sort of have as my starting point the 3.5%, but then I know that estrogen might increase the risk of strokes a little bit, so perhaps I'll up it by a percent or two. So perhaps I'll say that 5% is her ASCVD risk, And as you can tell, this is very much a gestalt. Some of my colleagues will do the same thing, use the two calculators, and just pick the higher number, which typically is the male sex, and use that for clinical decision making, which is a reasonable approach also. So with that risk calculator, with that risk calculated, it is reasonable to recommend some lifestyle interventions for her high blood pressure. I don't think aspirin would be indicated. And whether you want to prescribe a statin or not, well, if you look at the guidelines, she would fall in this category of patients who are between 40 and 75 with LDL cholesterol that is not extremely high and who does not have diabetes. And she would fall in the borderline risk category based on a risk of 5% if you use my method. And in addition to lifestyle, you might have a risk discussion and consider some of these ASCVD risk enhancers here. They do not specifically list here the hormone therapy, so just be aware of that. So the second question for you. So Boonsri has been on hormones for 27 years. She has also had the breast augmentation surgery. She's had vaginoplasty, and she's asking you about cancer screening. So which of the following cancers is she not at risk of developing? Breast, colon, prostate, cervix, or anal cancer? And the correct answer here is cervical cancer. In brief, as if the organ is present in the body, then the patient is at risk of developing cancer in that organ. And this patient, she has breast cancer because she has breast tissue. She certainly has a colon, so that can still develop cancer. She will still have a prostate. So all of the bottom surgeries or vaginoplasty, in her case, will leave the prostate intact. So she is at risk of prostate cancer. Now, she will not have a cervix. She never had a uterus, and so there's not a cervix. So she's not at risk of that. And anal cancer is, again, she has an anus, so she is at risk of anal cancer. Now, that's a different question from should you screen for these cancers? That is more difficult to answer. So which cancers should she be screened for? So I'll give you some thoughts, and hopefully they will be helpful to kind of frame your thinking. So let's start with breast cancer. Typically, the recommendation is if there is breast tissue present, then you do breast cancer screening using the female screening guidelines. In a trans feminine person, you might choose to wait 5 to 10 years after starting estrogen before starting screening. And in a trans masculine person, after mastectomy, there's very little breast tissue left, so you probably would not do anything like a mammogram, but there is a little bit of breast tissue left, so if there is a lump or a reason for concern, that should be taken seriously, but you would not screen because there's basically very little breast tissue left. For cervical cancer, so that's only applicable to transmasculine people. If they have not had a hysterectomy, so if they still have a cervix, then they should still get pap smears, again, using the standard guidelines for any woman, for cisgender women. Obtaining the pap smear can be quite uncomfortable. There are also higher rates of inadequate samples. So there have been a move towards self-collected pap smears, and that's certainly a consideration, although I will say it's not fully in routine clinical practice yet. How about prostate cancer? So that only applies to trans feminine people, all of whom will still have a prostate. Prostate cancer is controversial in a cisgender man, right? There are a lot of concerns about overdiagnosis and false positives and so on. So here in trans feminine patients, they typically have very low testosterone levels, so their risk of prostate cancer is most likely lower than that of a cisgender man. So that makes promoting screening even more difficult. So my approach is that I do obtain a PSA at baseline to make sure that the patient doesn't have a sort of pre-existing prostate cancer. And then you can choose to either just follow the male screening guidelines, but use a lower upper limit of normal of 1, because with a low testosterone, the PSA should be very low. Or you can choose to forego prostate cancer screening. And I typically have that conversation with my patients, and typically recommend that we stop prostate cancer screening if the testosterone level is low. Colon cancer screening, that will be by current guidelines, it's not affected by hormone therapy. And anal cancer screening, the guidelines are not are a little all over the place there, but I do mention it because it is typically recommended in individuals with HIV, and rates of HIV infection are higher in transgender patients. So depending on their risk factors, that is a consideration. But I should mention, it's more based on their HIV status and their sexual behaviors, as opposed to anything related to hormones or transgender status per se. So final sort of question is, well, how about a screening bone density? When should you obtain a screening bone density in a transgender woman? In cisgender women, the recommendation is at age 65 or earlier if there are certain risk factors. And in cisgender men, there are no real firm recommendations, but age 70 is often is a recommended age to obtain a bone density in cisgender men. Well, in transgender individuals, the International Society of Clinical Densitometry put together some guidelines in 2019, where they recommended obtaining a bone density, a DEXA scan, in any trans patient who has a history of hypogonadism. Obtain it right away. Obtain it at age 65 for anyone who has not had a history of hypogonadism, and between age 50 and 64 if the patient has other risk factors for osteoporosis. So that's very similar to the recommendations in cisgender, for cisgender women. Those risk factors might be things like a prior fracture, a family history, it might be steroid treatment, those types of things. In Boonsraid's case, she had these 11 years in her 20s into her 30s of not receiving any hormones. So because she had a gonadectomy as part of her bottom surgery, she would have been hypogonadal during those years. So we did obtain a bone density when I first met her, which luckily did not show osteoporosis. The other question in this setting is if the bone density shows osteopenia and we want to obtain, we want to use the FRAX calculator. Well, again, what sex do we put in the calculator? And we're back to the situation of the FRAX calculator was not created with a transgender reference population, so we are not going to get fully accurate results. So it's reasonable to calculate with both and then either choose which one you are going to trust more based on the hormonal history of the patient, or just go with the numbers that are the worst, that indicate the highest fracture risk. And then base your treatment decisions on that. So I went over a lot of topics, and you may be interested in learning more. So I want to highlight a few references. There are some very useful practical guidelines issued by the Endocrine Society back in 2017. Those are helpful for questions related to hormone treatment. If you're looking for more of a broader overview of transgender care, then I would recommend reading the standards of care that are issued by the World Professional Association of Transgender Health. For more details on primary care for trans individuals, the UCSF Center of Excellence for Transgender Health has a very useful website with, again, very practical information. And then finally, I didn't have time to talk about how to create an inclusive environment for your trans patients and more broadly LGBT patients in general. But there are lots of very useful webinars and other learning resources at the National LGBT Health Education Center webpage. So the key points: hormonal therapy. It involves, for trans people, blocking the gonadal hormones, unless they've had a gonadectomy, in which case you don't need to worry about that, and replacing with a hormone that matches the gender identity. And you do this under appropriate medical supervision. Primary care generally identical to that of cisgender individuals, but there are some specific considerations when it comes to cancer screening, where you want to basically know which organs the patient has. When it comes to cardiovascular risk, and other topics that we did not go into a lot of detail about today, such as minority stress and sexual health. And finally, leave your ideas about gender at the door and listen to your patients. You can learn so much about gender and gender identity, transgender, gender non-binary by just listening to your patient, and they'll teach you how to provide the best gender affirming care. Thank you very much.